Team, doctors preferred the places which were closer, of course, to Nairobi. And Kiambu was the most preferred because it had the most opportunities for working in private hospitals in Nairobi and elsewhere after hours or even during working hours, what doctors call locums. Yeah? So that's the other side. The fact that a centralized system, particularly where you have lack of transparency and, let's say, to be honest, corruption, the business of posting health workers in Africa House was very lucrative, so that health workers can be posted to the places which are more favorable to them. These were the conversations we had during the bombers chats around the Constitution. One of the most striking things I remember after devolution was seeing a tender by the county government of Garissa or Wajir very early on, and they had advertised for 30 maternity facilities, what you call like maternity hospital type things, facilities. And I said, these people, how can they build 30 maternity facilities in one fell swoop? But when I read the document in a little more detail, I realized that each of them was 6 beds. So what the county government was doing was taking the services closer to the people, while in a centralized system, it is more likely that one big facility would have been built, because that's the kind of facility that brings the sort of sophistication that health professionals want. So we have this tension between downward accountability and the sense that health professionals feel that they should be one body. And to point out, having a system with a health service commission, even if it goes all the way down, or something which is accountable to the top, we call that decentralization, not devolution. Because that is a decentralized structure, but it is parallel. Secondly, the idea that you have the state, there's a sense of conflating, a hearing of conflating the state with the national government. The state includes county government, and in fact our constitution is very clear that they are 2 distinct entities but are complementary and they should work together. That's a long sort of framing of the question. I do believe, how do we square the circle between, I think, what health professionals see as works for them in terms of service, professional development, and doing their work in the way that they think they should have some professional autonomy, and the downward accountability and dealing with the governance issues of the fact that in our own self-interest, we would like to work in the places which are most convenient, which are most lucrative, and where we are not as subject to sanctions for non-performance or for other things as we might be. And I believe there is merit in both sides. How do we then square that up? I believe, and I think as a matter of principle for us, that it should be possible for having a system which meets the professional development and that kind of thing and of health workers, but is also accountable where they work. So that perhaps, I don't know whether the health service, we can have a health service which employs, so that you're in the employment, the public service, but you have an internal market that you then have to be given a contract by a county. And if the county terminates your contract, you go back and you are, there are some organizations, the UN works like that these days. You are employed by the UN, but you have to get a job. But if you stay for so long and nobody wants you, then you have to leave. Because, to be honest, we cannot turn the clock back. The process of amending the Constitution so that it can look what the health workers want to do, let me finish, cannot happen. The task in front of us is to figure out a system that makes doctors accountable where they work and that they can be sanctioned for non-performance. Let us not pretend that doctors are angels. And let us not have any people stand on moral pedestals or professional pedestals and say we are the only ones who know how this should work. Let us be modest. As I said, we do need a healthcare system, but we also need governance. And I think what I want to hear from doctors is how do we deal with the governance and accountability and performance challenges of having a system which people are not accountable where they work and they are accountable to something they control. That's not the normal way that employment works.
Okay. And thank you very much for this question. And for so long, this has been the issue. The doctors, actually health workers, you must have a health system, and COVID brought out that well, that is centered around the health worker. For so long, we have been sacrificial lambs. You can as well die, but the politician has said, oh, I have a doctor there. We must move out of this number thing. The governor of Mandera claims this number of doctors, and county governments have done a fantastic job in health, in employing people and all. But the cycle, look at my cycle. If I was in devolution now, I would never have become a gynecologist. Think about it. I would never. I served the people of Machakos for 3 years. Then they said, we can now proceed you in your professional development, train you, but still work for us because we have paid for you your fees for a short time. And then after that, whatever you do, wherever you become a consultant, whatever, you can still continue being a public servant if you want. Yeah? But you have served your time. But you have looked at the bigger picture. In future, we will need a gynecologist. In Isiolo, which did not have a gynecologist. So, and that was before devolution. So even me, I can come and say, Isiolo had no gynecologist. Before devolution, by the time I left Isiolo District Hospital, it was an internship center, 4 consultants, 10 doctors. Also say that if I am to run the same, but the system as it is now, even as the counties claim to employ people, does not allow professional development and specialization and betterment of health of this country. It can't. Now that the governor is gone, and I'll give you a good example. Kenyatta National Hospital is employing medical officers with contracts which say that you cannot go to school. Professional development of medicine, in whatever area you are, you must have continuous development. You cannot stagnate there forever. And I'll tell you the problem we are having now. I'll use a simple, the basic doctor. The basic doctors have been employed. They work for their 3-4 years. Then when they want to go to school for specialization, they are told, by the way, that position that we have, we do not have someone to replace you. So they are stuck. You cannot employ someone because county government is saying there is a payroll. If you had a health service commission, this doctor, medical officer, is released to the health service commission. The health service commission provides a health worker for that position. This guy continues for training. The service continues to the people. Yeah. And when he finishes, we now look, Mandera kuna neurosurgery, went, and you post him there. Mandera will never sponsor a neurosurgery. It's too expensive for them. Yeah. So I think with that,
Thank you very much, Simon. Again, I appreciate your passion in what you're saying. And that's why this conversation is very important, so that we can listen carefully and avoid making political statements that are convenient when we actually have a challenge that we haven't addressed.
Yes.
It is very clear that there is an issue, and we need to figure out how that issue can be dealt with going forward. Listening to you, Simon, I'm just wondering, it is true, and by the way, what you have said is correct, because it came to IBEC, and many counties were saying, we have doctors who want to go at the county's expense to go and continue their education. So we have to do two things. We have to pay for this doctor to go learn, and then we have to hire another person to do what he was doing. So the counties were asking, this is too much. We cannot have it. We cannot carry, you know. So I agree with you that there is a challenge. Counties saying they do not have the resources to do that, to give you a bursary or a grant, a scholarship to go learn, and then hire somebody else. Is it possible for us to figure out how we can continue career progression, we can continue to train more personnel, more doctors, more neurosurgeons, and all the other health professionals in the context of devolution, or we must completely get out of it? I think we need to find a middle ground, a balance between those two. If we do, we will not only satisfy our health workers, but also keep devolution doing what they are doing. And Dr. I am sure you agree that devolution has done some things right. Yes. You agree with that?
Totally.
Yeah? So we just need to correct what they have not been able to do. And I agree with you 100%. That issue came to IBEC, where counties were saying, we don't have the money first to give a scholarship. And even if we did, it means we have to hire somebody else to do, because, you know, going to train for a postgrad is not going to take months. It's going to take minimum 3-4 years. So for those 4 years, somebody must deliver the service. So while I agree with you that a health commission who has a bigger deployment of doctors would easily replace that doctor from somewhere else, but we need to contextualize it around what we actually have now in our counties. And I think there is a possibility of having a conversation that will give us that balance.
And Dr. David said something that I really need to correct. There is no problem with a doctor working in Nairobi, wanting to work in Nairobi. Why? The terms and conditions, availability of social things are there. So it is upon the government to ensure that out there, you create an environment that allows me to have my children with high quality schools and things like that. Therefore, it's not a problem for people to move to a place where they want a betterment of their family. And on that note, currently as we speak, medical health care workers working for national government have better terms than we in the counties. People of my age, I've worked in
contemporaries.
My contemporaries, I have better terms of service at national and Nairobi than in county. Then why should you then expect me to be the sacrificial lamb? I'll give you one example. When they devolved, mortgage was not devolved. Mortgage was left for the national government employees. There is no county which is mortgage facility, despite them being taught by national government before devolution how to. We don't have. Then you expect your colleague has a house, you are there working in the county, your pay is less, your benefits are less, you have less access to social amenities. So for government, DP, it is the role of government to equalize health workers. And when I worked in ASAL, the day I was posted to Isiolo, my house allowance was reduced by 30,000. But we were posted with someone in another area whose allowance is that. Then people complain why do people want to come because of these disparities which have not been addressed. So you're treating people differently just because they work in different countries, yet we are qualified the same. Yeah. So in terms of progression, I think it's very important for government to equalize what the health workers are getting.
Agreed, Simon. Relax. Agreed. Asante sana.
Your Excellency, the Deputy President, the Kenya Kwanza leadership, all distinguished guests who assembled here today, including our host, the Catholic University. I'd like to first express my appreciation and express my gratitude on behalf of Kenya Association of Private Hospitals for inviting us to this forum. My name is Dr. Timothy Olweng. I'm the Secretary General of Kenya Association of Private Hospitals. I'd like to share a few perspectives. I had a brief presentation which was shared, but apparently they have some challenges with projection. So I'll just speak off the cuff. Now, in terms of what we would request anybody who potentially is going to be in government is in terms of certain changes that would improve our healthcare system. For example, universal health coverage is one of the topical issues and one of the most important things. So there has to be measures put in place in terms of accelerating the achievement of universal health coverage. Now, just to elucidate a little bit, the term universal health coverage is not necessarily fully understood by everyone. Universal health coverage has got three important facets. First, in terms of providing equitable access. It's not just access, but equitable. In our country at the moment, we have got access in general, but it's not equitable in terms of, there's a lot of regional disparities in terms of accessing healthcare. Access to health services and the entire range of health services that are required, but also they have to be of sufficient quality to be effective. Because in the absence of them being of sufficient quality to be effective, at best we can talk about universal health care, but not coverage. Now, one of the things that happens whenever we try to push towards universal health coverage is one of the easiest things to increase is access. So for example, if overnight we got the resources and we said the entire population can be able to go to health facilities and get health care, health system capacity cannot increase overnight. And so what has happened, even in our case, in the time when we have had this push towards UHC, is that quality has dropped. Because health system capacity you cannot train health workers, for example, you cannot build facilities and have the diagnostic facilities and so on overnight. Then in addition to that, there's the issue of financial risk protection. And this is one thing that the earlier speaker, especially Dr. David Ndii, brought up. We cannot be exposing people to financial hardship on account of procuring health services. And the only way that that is going to change is if we change the system via which we finance healthcare. Now, healthcare financing, for example, to achieve UHC, you can have two approaches. You can have a tax-based approach, where the government primarily is the provider of healthcare through taxes, and then you can also have social insurance as a vehicle, which is the avenue we're trying to use in Kenya. Now, in the absence of us having a pooling system where we're going to pool resources, we will never get rid of the issue of people being impoverished as they seek healthcare. So the pooling mechanisms can be through, for example, tax-based systems or social insurance, as I said, but we have to eliminate the issue of paying for healthcare at the point of service. So we have to have a pre-financing mechanism, and pre-financing mechanisms only work when you pool resources, either through social health insurance or through private insurance. Out-of-pocket payments need to be eliminated. In fact, in our country at the moment, I think the data that they have from the medium-term report on the Kenya Health Sector Strategic Plan said that still we have got 8% of our households are spending monthly more than 10% of the total health expenditures on healthcare. And that goes all the way to the point where we've got people who are being impoverished by procuring health services. The social health insurer, that is NHIF, there have been a lot of reforms that have been proposed of late, and it is in terms of trying to increase the pool or the base of people who are contributing to this fund. Now, insurance is about keeping your promise. And I don't think there's going to be any way, and I challenge anyone to, if you're going to put a mandatory system and say you're going to start arresting people who don't have NHIF insurance if they can afford to pay for it. It has to be that we deliver value and people see the benefit of belonging to this system. And NHIF has periodically has fallen short of this promise. And that is a challenge. Now, you have got the biggest challenge they have in terms of financing. You talk about mandatory contributions, yes. But the challenge is, and especially during the COVID period, we saw that there was a significant reduction in the voluntary contributions because people just didn't have the money or didn't see the value. So you've got people who contribute periodically when they perceive they're going to benefit. And that aspect of adverse selection is what even private insurance companies complain about. So people go and procure insurance when they anticipate a need. And after that has been taken care of, then they stop contributing. So one of the things that we have to do is look for a way in which we're going to have consistent contribution towards this scheme. And that's why the issue of the indigent people, I don't like that term very much. I think people who are, I'll say, economically disadvantaged should have contributions provided by government. So that's one of the ways in which we're going to increase the tax pool. But even as we talk about employers also contributing or matching their contributions that has been suggested, we have got to see an increased milieu of benefits. And that is what we have not seen in the current system. We have seen enhanced contributions, but we're not seeing the enhanced benefit packages being rolled out. Now, I've talked about out-of-pocket payments. Now, the other thing is the rising cost of healthcare. This is one of the items that we have got to handle and handle decisively. There has to be a systems approach in terms of dealing with this because it is not a simple fix. I come from the private health sector, and we have always been the bashing people, boys. When it comes to cost of healthcare, they say private hospitals are the ones who are charging too much. But the inputs, if you look at healthcare as a product, the inputs that produce that product, a lot of the time, we don't determine the cost of those. And that's why there has to be a collaborative effort and a concerted effort to bring down these costs. For example, it is not a secret that since, for example, we had unionization of healthcare workers in this country, the costs of payroll and costs of employing health workers have gone up. And that is a fact. We've got other inputs. For example, pharmaceutical supplies are a significant component of the health bills we pay in this country. Why is it, for example, that when you go to a place like India, we pay for the same branded drugs that you'd buy here for 3,000 shillings, you can get it for 600-700 shillings. I had an experience like that as a doctor when I went to a hospital in India, and I started looking at the packaging, wondering whether it's a genuine product they had given me, and I could see the pharmacist getting irritated, because for me, I could not believe I was getting it at the price I was getting it. So in the absence of us having a manufacturing sector that is robust, in the absence of government somehow entering the fray and trying to be able to regulate the prices of these commodities, we are not going to control the costs of health. In addition to that, there are other drivers of healthcare costs. All commodities. For example, government has a role to play. We have got a lot of taxation right now on a lot of the inputs that are coming in for the health sector. We cannot say that we are trying to promote universal health coverage, and yet at the same time, we are taxing the inputs that are going to bring down the costs of healthcare. I come from the private health sector, and we have seen in other sectors, for example, the government gives incentives. You've got people who get tax holidays when they come and invest. And the rest of us who are local investors are sitting and wondering, why would the foreign investors get preferential treatment over us? And if I was a foreign investor, before I come and invest in a market, I want to see how that government is treating its own people, because that becomes a reflection of how I'll be treated a short while down the road. So the cost of healthcare has got many facets, and that needs a concerted effort in terms of bringing down costs. One of the other major things is the mechanisms we have for healthcare provider compensation. For example, the traditional method, especially in the private health sector, has been fee for service. You walk into a facility, based on the inputs that are used in terms of providing care for you, a bill is generated, and that's how you pay for it. At the other end of the scale, the extreme end, we have got a system which we call capitation, where we decide that there are a certain number of people we want you to take care of their healthcare needs. We decide on a certain amount, we provide it to you, and in that way the risk has been transferred to you. So that's a capitation system. In the recent past, we've also got a fixed fee-for-service system, which especially private health insurers have been trying to introduce, and which the private sector feels is very unfair in the sense that they're transferring the risk of taking care of the clients to providers. And at all the time without notifying the clients that that is what they're doing. So you're told, we'll pay you for every outpatient visit 2,500 shillings. The person who is coming for care has not been told that's the arrangement, but what happens is the tendency is people try to reduce the costs of care per individual, and therefore quality of care goes down. And that is something I think we should not encourage in our system. The other thing which determines the healthcare and where government has got a major role to play is what we refer to as social health determinants. There are certain things, for example, socioeconomic factors that have been known to be associated with poor health outcomes. For example, the level of education has a bearing on people's health status. What kind of jobs they have, what kind of income they have, the kind of environments they live in, and other health behaviors, for example, smoking, their sexual habits, alcohol use, and so on. So you'll find the truth of the matter is the determinants of health that are within the control of the individual are actually a very small percentage, between 30 and 40%. The rest you're actually relying on other people. For example, as an individual, you cannot change the healthcare system in which you go to seek healthcare. And that's why, for example, we have a big challenge, which I would also like to mention at this point, the issue of cross-border contracting of health services. A while ago, I sat on a task force where you could see the intention was to try and restrict the number of Kenyans seeking treatment out of the country. And the tendency was try to block it and try and regulate and say you have to explain and get permission before you leave. And my opinion was, it is not workable. What we need to address is why are the people leaving this country? If it's an issue of cost, address the cost issue. If it's an issue of quality, that is a challenge to us as the healthcare providers, whether individual healthcare providers or institutional ones, we have to work together to improve that quality. If it's an issue of being able to get some of the expertise, let us work, as opposed to having people going out of the country. Can we have some of these other organizations or people from other countries come and work with us to increase our capacity so that we provide the care locally? So there are a lot of things that we have to work on in terms of intersectoral collaboration. When I talked about social health determinants, for example, infrastructure. There are a lot of people, especially in far-flung areas of this country, who can't be able to access a health facility because there is no road to be able to get to the facility. Or the security is not there for them to be able to go to hospital at night. Those become things that we need intersectoral collaboration, and that becomes the role of government. Agriculture, for example, food security and nutrition, that impacts on our health. And then there's the issue of violence and injuries, which has become a significant contributor to health morbidity and mortality. And I'm referring to violence and injuries. Again, there's a predilection for lower income areas. That is where there's a lot of it. But, for example, road traffic accidents, and especially in terms of the border sector, we have got a lot of health-related injuries that have occurred. So I think there is need for us to be able to regulate that sector to make it safer. Much as we appreciate that it's one that delivers a vital service, it needs to be regulated. I want to touch on the issue of poverty. There's a simple saying that poverty is not good for your health. In fact, poverty is bad for your health. And poverty is one of those things that is inextricably linked with poor health outcomes. Because there are so many deprivations that come from that. For example, it is a barrier to accessing healthcare because, for example, if you have to make out-of-pocket expenditure and you cannot be able to pay for it, you can't access the self-services you need. In addition to that, I've talked about violence, but poverty in itself, ill health itself is also a cause of poverty. So there's causality